Uh, So the topic for today is role of electron microscopy in renal biopsies. So as we know, light microscopy and immunofluorescence and majority of the centers, we get samples, they send samples for light microscopy, immunofluorescence, but electron microscopy is never the priority. So we always feel that with LM and IF, the diagnosis can be made, then why to go ahead with the electron microscopy? But I'm going to show you some cases, and I have analyzed my data also, in which it highlights that electron microscopy is a useful modality. And if we want a complete diagnosis of renal pathology, then electron microscopy should be done in all cases, at least in all native biopsies and in selected transplant biopsies. So I'll start with a brief introduction that kidney biopsy diagnosis is a complicated decision-making process, and it includes the element of uncertainty. And to decrease the influence of uncertainty, many methods are used in the study of biopsies, and the clinical data are carefully associated with the elements of the biopsy study. So the complete picture matters. So what is the clinical picture? What is the morphology? So for example, if the patient has nephrotic syndrome and no renal dysfunction, serum creatinine is normal, so we know that we need to look at the glomerular compartment. The pathology lies in the glomeruli. And in the glomeruli, if you find there is a membrane thickening, morphologically light microscopy diagnosis will be membranous. Then you proceed with the immunofluorescence. So immunofluorescence, if it shows, we expect that if light microscopy is showing a morphology of membranous glomerulopathy, we expect there should be IgG, surely, which should be there along the capillary loops. So if IgG is there along the capillary loops, that makes our life simpler, and we diagnose it that this is membranous if C1q is not there. And now we have PLA2R thrombospondin, and by doing that, we can categorize membranous, whether it is primary or secondary, and whether it is PLA2R or thrombospondin associated. And now there are one or two more antibodies which are like NEL1 associated MGN. So so role of electron microscopy in such a situation where you have already diagnosed membranous, where you have already categorized this membranous into PLA2R associated membranous or thrombospondin associated membranous, the role of electron microscopy is limited. But on the other hand, if you find that immunofluorescence is negative, but morphology is showing thickening of the glomerular capillary wall, then EM will be useful in telling us that what is the thing which is causing so significant thickening. Then you will all, as a pathologist, will always discuss with the concerned physician, concerned nephrologist, that we are seeing thickening of the membrane, which is commonly seen in diabetes, which can be seen in hypertension. So does this patient or some kind or light chain deposition disease? So we'll discuss whether this patient is diabetic, if there is a history of diabetes, and on EM also, we find diffuse homogeneous thickening of the glomerular basement membrane. So everything fits with that diagnosis of membranous. Now, with the diagnosis of diabetes, the only thing is diabetic nephropathy. The only problem is if patient has nephrotic syndrome, then that thickening of the membrane can't explain so significant proteinuria. Early diabetic nephropathy can't explain. So electron microscopy will be useful in a scenario that it will, first of all, we will be able to assess the thickness of the GBM, glomerular basement membrane, and in addition, since this patient has nephrotic syndrome, we would like to have a look at the foot processes also. If there is a foot process effacement extensive, we'll say, okay, there is early diabetes, but the cause for this proteinuria is the diffuse podocytic foot process effacement. So possibly the proteinuria is because of the podocytopathy. So that diagnosis is made only on electron microscopy, because an LN and IF has excluded immune complex mediated disease like membranous, IgA for the cause of this massive proteinuria. So electron microscopy has been widely utilized in the evaluation of kidney biopsies. However, few studies have critically assessed its diagnostic value. The proper justification for the routine use of EM in the study of kidney biopsies comes from studies published in the 60s. EM was permitted to arrive at a substantially different diagnosis to the light microscopy in 11 to 13% cases. So that time it was thought that it is only in 11 to 13% cases EM will give you a very useful information or will give you the final diagnosis. Otherwise, by L and IF, you will be able to diagnose majority of these cases, and found that EM significantly contributed to the diagnosis only in 6% of the cases. So these studies concluded that EM is not necessarily a routine procedure in the study of renal biopsies, and that it is a luxury more than a necessity. And these are the few studies on electron microscopy. So I just want to point out that majority of the pediatric pathology, pediatric renal biopsies which we receive, we always get EM in those cases. And even in this study in 2011, it was shown that it is essential for diagnosis in 65% of the pediatric nephropathology cases, and it provides helpful diagnostic information in 24% cases, and only in 11% cases it was said that it is not required for the diagnosis. And if you look at other studies also, 1994 study, 25% said that it is not required, 58% study, 58% in 1996 by Haas et al. They suggested that EM is not required in 58% of the diagnosis. So there is varied findings. And so this data highlights that practically around 40 to 60% of the cases, EM is not required, what it shows. So what I'm going to do is I will categorize some glomerular pathologies, and I'll say that how EM will be useful in diagnosing these glomerular pathologies, and how EM is not required in some of the glomerular diseases. Okay, so kidney biopsy. So ideally, you should get 3 samples: one in formalin, one in Michel's media, and the other one in glutaldehyde. And for EM, it has to be in glutaldehyde. Many a times, when we get only 2 biopsy sample tissues, that means in a formalin and normal saline or Michel's media, we subject the formalin fixed tissue for electron microscopic studies, where we feel that okay, because EM will be useful. So that decision whether EM will be useful or is definitely required in any case, it depends upon what is there on the LN and IF morphology. So just to highlight, this is a light microscopy, how a glomerulus looks like. So as we know that glomerulus, this is a PS stain, so you can see the capillary loops, you can see intervening mesangium which is there, and these are the nuclei which are there in the mesangium. 1 or 2 nuclei means there is no mesangial hypercellulite. It is a normal looking glomerulus with a Bowman's capsule, and these are the tubules. So whenever we report any kidney biopsy, we always look at 3 compartments: the glomerular compartment, the tubular interstitial compartment, and the vascular compartment. And then the second modality is immunofluorescence. So immunofluorescence this is a immunofluorescence microscope. So immunofluorescence will tell us whether there are immune complexes which are there. So this is a case of membranous, where you can see the IgG which is deposited along the glomerular capillary loops. And electron microscopy is this is how electron microscope looks like. And I'll show you, I'll explain what is the normal structure. So in the images in the presentation later on. So this is the light microscopy view, where you can see where I told you that there are 3 compartments we look at. There is a glomerular compartment, there is a tubular interstitial compartment. So these are the tubules. Normally tubules are arranged in a back-to-back manner. There will be interstitium. So this is the tubular interstitial compartment, this is the glomerular compartment, and then the third is the vascular compartment. So when we look under light microscope or under immunofluorescence, the magnification is like 2 times to 40 times magnification. But when we look at electron microscope, the magnification starts from 200 times to 50,000 times. So it is extremely high magnification. You can look at structures. So this is a normal ultrastructure morphology of a glomerulus, where you can find that this is a GBM, this is a glomerular basement membrane, this is the glomerular basement membrane, this is the inside part of the glomerular capillary loop. This is the this is outside the glomerular capillary loop. So that means this is the Bowman's capsule. This is the urinary space. What you can see, any proliferation which occurs in the urinary space is called as extracapillary proliferation, and any proliferation which is happening inside the capillary loop, that is called as endocapillary proliferation. So what you are seeing here is, this is a podocyte nucleus, this is a podocyte cytoplasm, and these are the foot processes of the podocyte. So podocyte is like an octopus. It has got 1 nucleus, but it will send its cytoplasmic extensions to significant number of capillary loops. So one podocyte can cover a lot of glomerular capillary loops. And the foot processes are nothing but tertiary divisions of the tertiary processes of the cytoplasm of the podocyte. So you can see these foot processes which are not effaced, which are absolutely fine. This is a normal EM morphology of a glomerulus. And this is just for comparison. So you can compare this. You can see these projections along the glomerular basement membrane. So that means normal foot processes or maintained foot processes. And on the other hand, you can see here that there is complete effacement of fusion of the foot processes. So what you're finding here is there is a large vacuole kind of thing. So this is the outside part of the glomerular basement membrane. So here is a podocyte, which is not seen, but this is a podocyte cytoplasm showing cytoplasmic vacuolization. And this happens whenever there is a proteinuria state. So you're finding diffuse foot process effacement and there is cytoplasmic vacuolization also. So when there is a diffuse foot process effacement and if on light microscopy morphology is normal and on immunofluorescence you find no immune deposits or maybe very minimal IgM in the mesangium, so the diagnosis is either MCD or unsampled FSGS. Okay, so if you find a FSGS lesion in the light microscopy, immunofluorescence is negative, and you find this kind of a foot process effacement, diffuse foot process effacement, then you label that as primary podocytopathy or primary FSGS. So the percentage, when we say that if more than 80% of the capillary loops or 80% of the podocytes show foot process effacement, that is called as diffuse podocytic foot process effacement. And when less than 80% show, it is called as focal podocytic foot process effacement. So if there is a diffuse podocytic foot process effacement, then you think of primary podocytopathy. And if the foot process effacement is very focal, you think in terms of a secondary podocytopathy. So diseases like diabetes, hypertension, obesity, then they can produce a focal foot process effacement. If there is a diffuse foot process effacement, there is role of steroids and all that immunosuppressive therapy. But if there is a very minimal or focal foot process effacement, you just need to correct the underlying pathology, which could be diabetes, which could be hypertension, which could be obesity. So on routine HND, this is the morphology. If you see, there is complete thickening of the glomerular capillary wall, or I can say diffuse thickening of the glomerular capillary wall. The underlying glomerular tuft is showing no proliferation. So whatever you are seeing, these nuclei, they are lying outside the glomerular capillary loop. There is no nucleus inside the capillary loop. So capillary loops are empty. So that means there is no endocapillary proliferation. This is a Bowman's capsule. This is a urinary space. So in the urinary space also, there are no cells. That means no extra capillary proliferation or crescent formation. Okay, but there is diffuse thickening of the glomerular capillary wall. So morphologically, it is membranous. When we do immunofluorescence, it will show deposits. And on electron microscopy, what you'll find is, I've shown you the normal GPM. So what you're going to see in a membranous is all these immune complex mediated disease, they have electron dense areas. So these immune deposits appear as electron dense deposits. You can see these dark color deposits along the GPM. So this is a glomerular basement membrane. It has got an endothelial side of the glomerular basement membrane and epithelial side. So when I say epithelial side, that means visceral epithelial cell or podocyte. So if you find immune complexes in the epithelial side, that means just beneath the podocyte or visceral epithelial cell, these are called as subepithelial deposit. Now, if you find deposits here beneath the or towards the endothelial side, which are not seen in this case, then they are called as subendothelial deposits. So in this case, there is membranous and there are diffuse subepithelial deposits. So if somebody says that are these deposits surely along the glomerular capillary loop or they are in the mesangium also? So in this case, if you look at this immunofluorescence, there are bright granular deposits along the capillary loop, but some areas it appears that in the mesangium also there is some staining. So the exact localization also, what happens is it is a three-dimensional kind of a structure, glomerulus. So there will be some area, there will be some sections of glomerulus where it will appear. It might appear that the deposits are in the mesangium, but actually they are only along the capillary loops. The exact localization of deposits, whether they are along the capillary loop or mesangium, can be done on electron microscopy. The exact further localization of deposit, whether they are towards the subepithelial side, intramembranous, or they are subendothelial deposits, that also can be seen, or that can also be commented only on electron microscopy. So looking at the immunofluorescence, it is impossible to say whether these deposits are subepithelial or subendothelial. Okay. So you have to remember exact localization of deposits will be done on electron microscopy. So you can see here that uh, deposits along the capillary loops are there, whether they are along the capillary loops or mesenteric. So this is a IgG, which I've shown you before. This is a case of membranous, and this is a case of IgA nephropathy, where you find deposits are predominantly in the mesenteric area. So this is membranous and this is IgA nephropathy. So as I told you, the exact localization of deposits can be done only on electron microscopy. So this is the image which shows that there is a GPM and there are deposit. This is the RBC. So this is the endothelial aspect of the GPM, and this outside area is a epithelial side of the GPM. So though we are not seeing any cytoplasmic projections of podocyte, no podocytic nucleus is there, but I'm telling you this GPM, this is the endothelial side, this is a subepithelial side. So you can see these deposits along the epithelial side or toward or beneath the visceral podocyte or visceral epithelial cells. So these are subepithelial deposits. Occasionally you don't find any these small dark color deposits, you find a large hump-like deposit like this. So these hump-like deposits can be seen in post-infectious glomerular nephritis. If the deposits are dense intramembranous, you suspect dense deposit disease. And if the deposits are seen predominantly in the mesangial area, so you can see these, these are the glomerular capillary loops, and you see these dark deposits only in the mesangial. So this kind of morphology you get to see commonly in IgA nephropathy. So when we look at a basic structure pattern of glomerular injury, there could be epithelial cell disease or minimal change disease. There could be FSGS, membranous nephropathy, MPGN, diffuse proliferative, crescentic, focal proliferative necrotizing GN, mesangial. So all these morphological patterns or basic structure pattern of glomerular injury are made on light microscopic morphology. So when you look at basement membrane abnormality, now it is very important that you should always remember that basement membrane abnormality can be picked up only on electron microscopy. So when I say basement membrane abnormality, that means I'm talking about Alport's disease and thin basement membrane disease. So this is an image, you can see this is the GPM, and this GPM is thinned out, and the foot processes are absolutely preserved. So there is no evidence of podocytopathy, but look at the GPM. So normally GPM has got lamina externa, which is the pale line, lamina densa, which is the inside part, and lamina interna, which is also a pale line. So but the thickness of this GPM is this is a thin GPM. So if the patient has episodes of microscopic recurrent hematuria, and you find a thin immunofluorescence is negative, morphology is normal, and you find thin GPM on the electron microscopy, then the diagnosis is thin basement membrane disease. On the other hand, if the same kind of clinical picture is there, but you find this is the GPM which is normal looking, because you can see these, this is the lamina externa, this is the lamina interna, inside is the lamina densa, and GPM thickness looks fine. But as compared to this capillary loop or this GPM, the other area of the same glomerulus show that the GPM, the lamina densa, which should be this dark, it is undergoing fragmentation. So the lamina densa is undergoing some whitish areas are there within the lamina densa. This is called as basket weave pattern of GPM, or basket weave pattern of fragmentation of the lamina densa, and this is commonly seen in Alport's disease. So I'll show you a few cases. So 30-year male with nephrotic syndrome, 24-hour urinary protein is 3.8 gram, serum creatinine is fine. So clinical diagnosis of MG and FSGS, minimal changes is. You find light microscopy, a normal looking glomerulus, no proliferative changes, no membrane thickening. Immunofluorescence is negative for all immunoglobulins and complement, but the EM shows diffuse podocytic foot process effacement. So if there are adequate number of glomuli, maybe 15-20 glomuli, and you find no FSGS lesion, no synecdoche formation, no glomerular sclerosis, so and you find this kind of morphology, then you can label this case as minimal change disease. So with this kind of a morphology, there are only two differential diagnoses. If patient has full-blown nephrotic, either it is a minimal change disease or it is an unsampled FSGS. When I say unsampled FSGS, that means you are not finding FSGS lesion in the biopsy sample what is provided to you. So if I'm seeing a biopsy sample in which there are 20 glomuli, all those 20 glomuli are showing normal morphology and there is no segmental lesion. So I label that as unsampled FSGS if immunofluorescence is negative. Because many times when we label some case as minimal change disease, a call will come that despite giving steroid, there is no response. This is like steroid resistant. So kindly have a relook at a case, at this case, if there is any segmental sclerosis lesion. But I'm telling you that more the number of glomuli, more the chances of picking up the segmental lesion. So I always write normal glomerular morphology, and I will say the morphological possibility consider a minimal change disease or unsampled FSGS and correlate with the steroid response. So this is minimal change disease. So similar kind of presentation, but this is a 65-year-old male with nephrotic syndrome. Same clinical possibilities. So nephrotic syndrome, normal glomerular morphology was there, and the immunofluorescence was negative. So morphological possibility consider MCD, unsampled FSGS, Alports if this patient has hematuria also, and there is some proteinuria, not full-blown nephrotic, but Alports, advanced Alports can have full-blown nephrotic as well. But you have to remember, this is an elderly 65-year-old male. So elderly patient, whenever there is a nephrotic syndrome, before we label them as either MCD or unsampled FSGS, we need to be very careful that we are not missing on anything. So when we did immunofluorescence, when we did electron microscopy showed this GPM, which is fine, preserve food processes. And suddenly you see in this area, there is some, there is something which is there. So, and this appears like this is towards the subepithelial side, okay? So when I went to the higher magnification of this area, so there are fibrils which are randomly arranged. So randomly arranged fibrils and this kind of a morphology. So this, whenever you find these kind of randomly arranged fibrils, the first suspicion should be whether I'm dealing with some amyloid deposition. And that too, because morphology was normal, early amyloid may be missed on routine microscopy, because early amyloid will be picked up only on electron microscopy. So what we did paraffin immunofluorescence because these slides were reported outside as minimal change disease, but patient was not responded to therapy. So a stage came when the nephrologist thought that whether we should give rituximab, but they thought that let's review this case before we give rituximab. So when this was reviewed, the morphology was normal IF. So we did paraffin IF and we look at kappa lambda carefully. So in the kappa, there was some area which was showing 3+ kind of staining in the mesentery, and there was lambda which was completely negative. So now whenever one light chain is completely negative, you should always think you can think of a light chain kind of restriction. Okay. So in this case, lambda was absolutely negative and kappa was there. So this was early amyloidosis, kappa restricted. So this diagnosis was made on electron microscopy, but then retrospectively, after looking at the EM finding, we did paraffin immunofluorescence on the paraffin block, and there was kappa restriction. So role of EM, if we look at IgA nephropathy, it is very limited. IgA nephropathy diagnosis can be made on LM plus IF. Okay. And one more thing, looking at EM, you can't say if these deposits are of IgA nephropathy or these deposits are of MPGN. So EM will only tell you that whether these electron dense deposits are placed in the along the GPM or they are placed in the mesentery. So the role of EM in IgA nephropathy is limited only if you want to rule out a coexistent disease. For example, there is a case of IgA nephropathy. There are 10 glomuli, and this clinically patient has nephrotic syndrome. And there are 10 glomuli, and few glomuli are showing minimum mesenteric hypercellularity. There is no segmental sclerosis. There is no endocapillary proliferation, no extracapillary or crescents. But the problem is with this kind of IgA nephropathy with minimum mesenteric hypercellularity, no tubular ischemic chronicity, no glomerular sclerosis, it is not possible to explain so massive proteinuria if this patient has. So if we do electron microscopy, and if on electron microscopy you find diffuse photocytic foot process effacement, then this finding suggests that there is a coexistent either minimal change disease or primary podocytopathy in this case. So role of EM in IgA nephropathy is just to rule out coexistent disease. Even for membranous, now this is a 35-year female with nephrotic syndrome. So clinical suspicion was MGN. You can see there is membrane thickening. IgG showed granular deposits along the capillary loop. So everything is fine for membranous glomerulopathy. And when we do other immunoglobulins, C1q is negative or very minimal. So C1q should be 3+ to be labeled as lupus or class 5 lupus nephritis. And it was like there were deposits in IgG, and even the EM shows subepithelial deposit. So there was a time whether when the nephrologist or treating physician used to ask pathologist whether I'm dealing with a primary MGN or secondary MGN, and there are 100 of causes for secondary MGN. And we used to say that on electron microscopy, there are no deposits in the mesangium, there are no deposits in the subendothelial aspect. So I feel it is primary membranous, but that is not correct. Nowadays, we have IgG subclasses, we have PLA2R, we have thrombospondin. To categorize this membranous, whether it is a PLA2R associated MGN, thrombospondin associated MGN, NEL1 associated MGN, or whether it is a lupus MGN. So important thing is, if in IgG subclasses you find dominantly IgG4 staining and less or minimal IgG1, IgG2 and 3 are negative, dominant IgG4 staining is commonly seen in primary membranous or malignancy associated MGNs. So by doing PLA2 or thrombospondin, by doing IgG subclasses, you will be able to categorize this MGN as PLA2 or associated MGN. So role of electron microscopy in MGN is very limited. So PLA2 or thrombospondin positive only for confirmation of the diagnosis. So if PLA2 or thrombospondin are positive, then role of electron microscopy is mainly for confirmation of the diagnosis and for staging membranous, whether it is stage 1 or stage 4. But EM will be useful in cases where you find the morphology is very early MGN. There is no definite thickening, and you find very segmental IgG staining. So there is an entity called as segmental membranous, in which the immune deposits are seen not throughout the capillary loops, but they are seen only in a segmental distribution. Then there is an entity called as MGN or membranous glomerulonephritis with masked IgG deposit. That means you're finding a thickening of the membrane, but there are no IgG deposits. And on EM, you are able to see deposits. Okay, so that means those deposits are there, but they are not picked up on the routine immunofluorescence. And if you do paraffin immunofluorescence, those deposits will stain for IgG. So that means MGN morphology is of light microscopy morphology is consistent with membranous. Immunofluorescence, routine immunofluorescence is negative. But when you do paraffin immunofluorescence, it shows deposits, IgG deposit. That is why it is called as MGN with masked IgG deposits. And this comes under cases of dysproteinemic state or MGRS kind of a setting. Then there is MGN with dysproteinemia. If you find membranous, but there is kappa or lambda light chain restriction, that is called as MGN with dysproteinemia. EM should be done in these kind of scenario also. So I'll show you one case, 40 male known case of diabetes for last 2 years. Now the diabetes is only for 2 years. There is history of swelling of feet for last 2 years. Is absolute B cell lymphocyte count was 3105. That is called as a monoclonal B cell lymphocytosis or MBLs. So flow cytometry showed 523 positive, which is consistent with the monoclonal B cell lymphocytosis. SPEP showed no M-band. Serum free light chain assays ratio was 1:5. Now the important thing is now for this kind of a clinical setting of monoclonal B cell lymphocytosis, normally you don't give any treatment because it is a non-neoplastic disease. So you just need to monitor the blood count. So patient asks that we need to monitor only the CBC and absolute lymphocyte count every 6 months, and no medication is required for monoclonal B cell lymphocytosis. Now this patient develops pedal edema, which has worsened in the last 3 months, and urine routine microscopy showed 3+ proteins and RBCs were 25 to 30. And present 24-hour urine protein is 2.85. Serum creatinine was 0.82. So you find these are this is the interstitium, and you find a lot of foamy cells in the interstitium. These are called as interstitial foam cells. Presence of interstitial foam cells is commonly seen in nephrotic states. So there is one globally sclerosed glomerulus. Now this is a Bowman's capsule. You can see a hyalinotic lesion just attached to the Bowman's capsule, inside part of the Bowman's capsule. This is called as a capsular drop. Okay, there is some thickening of the membrane. So morphologically, it could be diabetic thing because there is some mesangial expansion also which is there, but no mesangial hypercellularity, but no nodular glomerulosclerosis lesion. So practically early diabetes. This is a Mason's trichome stain which shows that there is a segmental sclerosis lesion also, and Mason's trichome also highlight these interstitial foam cells. This is just to highlight the same segmental sclerosis lesion. So practically what we have found is morphological possibilities only on LM. That is whether we are dealing with MGN with FSGS lesion and there is a capsular drop for which I don't know the reason. The second possibility is whether it is FSGS with early diabetic nephropathy or it is diabetic nephropathy with secondary FSGS lesion. So this possibility is unlikely, diabetic nephropathy with secondary FSGS lesion, because only advanced diabetic nephropathy will produce so significant proteinuria. So in this case, there are no advanced diabetic changes. There are no KW lesions. There is no evidence of tubular atrophy, interstitial fibrosis, significant tubular atrophy, interstitial fibrosis. So morphologically, the suspicion was whether this is MGN with FSGS lesion or this is a primary or secondary FSGS with early diabetic nephropathy. Now, distinction between both these entities can be done on immunofluorescence. So we did immunofluorescence. IgG showed that there is some deposits along the capillary loop, and these deposits were negative for kappa but positive for lambda. So there is, so whichever immunoglobulin is there, whichever light chain is there, that is called as restricted. So by word restricted, you will think that when I say lambda restricted, that means lambda is negative, but actually it is not correct. When I say lambda is restricted, that means only lambda is positive and kappa is negative. Okay. So whichever light chain is positive, that is called as restricted. So there is lambda light chain restriction in this case. I thought that I'll do paraffin immunofluorescence also to be sure that surely there is lambda restriction. So paraffin immunofluorescence also show this kind of a segmental deposits and which are negative for kappa but positive for lambda. So diagnosis on LNM-IF was like whether we are dealing with a MGN with dysproteinemia or something else. So most likely that was a suspicion. When we did electron microscopy showed that this is the endothelial side and this is the epithelial side. So you can see the deposits which are there, and just beneath the deposit you find some kind of a, these are called as substructure. So when you find some kind of a elongated tubules or some fibrillary kind of structures within the deposit, that is called as substructure formation within the deposits. So substructure formation can be seen in lupus, but it can also be seen in MGRS lesions. So you can find these deposits which are there, and some of the deposits, there are some kind of structures which are there. And if you look at these structures, they have length 31 nanometers to 46 nanometers. So these are unusual findings. The moment you find this kind of a fibrillary architecture within the deposits or just beneath the deposit, you should always suspect a MGRS lesion. And even in the mesangium, there was some fibrillary kind of architecture in the mesangium also. So you can see these kind of, not, I won't say fibrils, there is some kind of tubule formation in the mesangium. You can find this dark color structure inside luminous pale. So this is a tubular kind of thing which was there. So so tubular structure is commonly seen in MGRS lesions. So membranous pattern of globular injury, and it is a MGRS entity, a monoclonal gammopathy of renal significance. So now if you look at lupus also, lupus, if C1q is there and full house immunofluorescence pattern is there, diagnosis of lupus is not a problem. So EM is not required actually. And when you do IgG subclasses, you will find IgG4 is negative in lupus or secondary membranous, but other IgG subclasses will be there. So IgG1, IgG2, IgG3 will be there. I just skipped this thing because what I'm trying to highlight is that I analyzed cases where there was known case of SLE, and it was like, or some cases where there was first episode of nephrotic syndrome. So what I want to highlight is there was all the lupus nephritis biopsy will not show full house immunofluorescence pattern, and class 5 lupus is very different because a significant number of patients will have normal serum complement levels and they will not have C1q staining. So if there is absence of C1q or if the complement levels are normal, it could still be class 5 lupus nephritis. So lupus diagnosis, if we look on a kidney biopsy, if you do IgG subclasses, if you do PLA2 or thrombus bonding, which show negative staining, electron microscopy role will be only to say that if there are tubular reticular inclusions, if there are mesangial or subendothelial deposits, and to rule out any lupus podocytopathy. So in lupus, the role of EM is practically for diagnosing lupus podocytopathy and for demonstrating if there are any tubular reticular inclusions or mesangial or subendothelial deposits. So EM in lupus nephritis, many times I ask for EM if morphologically I feel it is a class 5 lupus nephritis. But if I'm not sure whether these deposits are throughout along the capillary loop or they are in the mesenterium, then I'll ask for EM, because as I've told you, exact localization of deposits is done only on electron microscopy. So, or in lupus photocytopathy, EM will be important because it will demonstrate photocytic food process effacement. It is not required for confirmation of proliferative component, because that proliferative component you have already diagnosed on LM. If there are crescents or endocapillary proliferation, they are all already diagnosed on LM. So practically, for confirming the class 5 component and for ruling out lupus photocytopathy, rule of EM. So I'll come to another case. 47, a male with hypertension for the last 8 years on antihypertensives, no diabetes, edema in 2014, urine protein in 2014 was 4+, and biopsy reported as membranous. Baseline creatinine was 1.9, taken cyclosporin and oxon, presently again nephrotic state. So morphologically, this case was not looking like membranous because it showed a morphology with mesangial expansion, which was there. And this is a PS stain. And if you look at the membrane is not that thick. Whenever we say this membrane is thick or thin, it is based on the thickness of the tubular basement membrane. So just compare this membrane with tubular basement membrane, it is similar. But in some areas, the thickening was more. So in this area, it looks more thicker than this tubular basement membrane. But if you look at the mesangium, it is PS positive mesangium, but there seems to be dominant finding in the mesangium. It seems that the mesangium is expanded. And possibly there is a segmentous sclerosis lesion also. When we did the stains, there was albumin which was negative. IgG showed some kind of a staining. IgA and other immunoglobulins are complement negative. Kappa lambda also show. Sorry. So this image shows that this is a IgG which is showing a smudgy staining in the present case, and this is the IgG of membranous, which is showing a granular staining. You can see the granular staining here, and you can see smudgy staining here. So this kind of a scenario can be seen only if you find, sorry. Okay, so IgG granular staining. So this is like a classical membranous, and the present case is not showing granular staining. It is showing very smudgy kind of staining. You can compare it because in granules you find a dot like structures along the capillary rows, but here you are not finding those kind of dots. You are finding some kind of a non-specific staining. But yes, IgG is there. It is not that IgG is absent. And when we did electron microscopy, there were fibrillary kind of deposits in this area. So diagnosis was, it was a fibrillary glomerulonephritis, which was wrongly labeled as membranous because IgG pattern of staining was not seen. It was only seen that IgG is positive, but you should always comment whether it is a granular positivity or whether it is a smudgy positivity. If there is smudgy positivity, it goes in favor of fibrillary. And then there are now new markers, DNA JP9, which we can do to confirm whether it is fibrillary or non-fibrillary, but EM will be required. So other deposition disease like amyloid, monoclonal immunoglobulin deposition disease, fibrillary GN, collagenofibrotic glomerulopathy, fibronectin glomerulopathy, immunotectoid. So you need to do electron microscopy. EM plays a role in diagnosis of these deposition disease. EM has a role in diagnosing MPGN. So in immune complex mediated MPGN, it is not required, but it is required for categorization of C3 glomerulopathy. Because when you see MPGN pattern and there are only C3 deposits, the diagnosis on LN and LM and IF is, it is a C3 glomerulopathy. So this includes two entities. It could be either C3 glomerulonephritis or it could be dense deposit disease. And that categorization can be done only on electron microscopy. Elderly patient with diagnosis of C3 glomerulopathy, you should always do EM because there could be MGRS cases, because C3 glomerulopathy is a disease of young people and children. So if you give a diagnosis of C3 glomerulopathy in elderly patient, those patients should always be investigated for underlying monoclonal disorder, monoclonal disease, because it is said that amount of some amount of or small amount of that monoclonal protein that cause activation of the complement pathway, and due to that activation there will be deposition of C3, what you see. MPGN with monoclonal deposits, or MPGN with dysproteinemia, EM should be done. So I'll just rush through this case. 29-year male, nephrotic range proteinuria, hypertension, 24-hour unit was 5.5 grams, deranged renal function, past history of pulmonary tuberculosis 15 years back. So looking at this biopsy, you can see the membrane. There is a non-uniform kind of thickening of the membrane which is there. You can find a thin membrane like this and suddenly a thick membrane like this. So I'll show you under oil immersion also. So if you see, this is a very thick membrane, a thick membrane like this, interrupted. There is an interruption of the thickness of the glomerular basement membrane. And just compare this membrane, which is this area of the glomerular capillary basement membrane, which is thin. Okay, so there is thin and thick membrane, and places the thickness is very significant. Okay, and this is a Mason's trichome stain. So when immunofluorescence was not there, so people used to do Mason's trichome stain to demonstrate deposits. So Mason's trichome stain shows that there are red color deposits along the mesenchyma and along the glomerular capillary loop. So IgG, IgA, and C3, it was negative. Okay, or C3 was very minimal. So it was confusing because all the immunoglobulins are negative, the complement is negative, and morphology is showing those kind of massive deposits. Even on Mason's trichome, you can find those deposits. When we did electron microscopy showed dense osmophilic deposits along the glomerular basement membrane. So that means these deposits are made up of something. So then we did C4D immunohistochemistry. So there is an entity called as C4D DDD. Okay, so this case was a C4D, a dense deposit disease, which was there, and it showed these kind of deposits, and immunofluorescence was negative. 7, a female, recurrent episodes of swelling, onset 2007, progression was there, steroids for 6 weeks daily, 2 milligram, no response, shifted to alternate day, tapered and stopped, ACE inhibitors was started, and this patient was labeled as steroid resistant nephrotic. So this patient had a this child has a very classical clinical history, that strong family history. There was a ESRD in the grandfather at the age of 52. Then her father actually also had kidney disease at the age of 34, and both the kids, so 7-year and 3-year-old, both had renal dysfunction, or both had proteinuria. So actually, with each passing decade, or with this disease is coming at a more younger age. So the grandfather had a kidney disease at 52 years. Father had a disease at the age of 34 years, and the children, they are having this disease at age of 3 years and 7 years. So these were the complement levels which were towards the low side in the father, as well as in the child on which the biopsy was done. C3 normal range is 70 to 110. So familial hypocomplementemia kind of GN, familial MPGN, and this process that a disease coming early with each generation, that is called as anticipation phenomena. So when you look at the morphology, it had diffuse thickening of the glomerular capillary loop. Mason's trichome highlights these kind of pushnophilic deposits, and this was C3, which was strong. But when you look at morphology, there were areas in some of the capillary loop which were subendothelial and which were less dense, and there were some areas on the glomerular capillary loop which were very dense. So more dense, that means more dark color deposits and some light color deposits. So this was like a mixture of deposits. So when you find more dense deposit, it is more consistent with dense deposit disease. And when you find a slightly light color deposit, it is more consistent with C3 glomerulonephritis. So this was an overlap of dense deposit disease and C3 glomerulonephritis. We also published this case because when we did molecular studies and all that stuff, so there was a novel CFHR1, CFHR5 mutation hybrid leads to mutation was found, and which led to a familial dominant C3 globulopathy. So I'll just rush through this case. I just want to highlight that when immunofluorescence is negative and morphology looks like there should be something in the immunofluorescence, you should always do electron microscopy. That is clear. So EM in transplant, I'll just tell you that EM in transplant is useful for demonstrating early chronic antibody mediated rejection. because this was a case POD 5 months, absolutely normal looking morphology. But when you look at the peritubular capillary, there was significant multilayering of the peritubular capillary. So this is a peritubular capillary, this is the endothelial set, and you can find around 6 to 7 layers or more. If you find more than 7 layers in any PTC, that is peritubular capillary basement membrane multilayering. Uh, uh, this was a case post-transplant with proteinuria and minimal, no significant renal dysfunction, and it showed C4D, which was positive in the peritubular capillaries and also along the glomerular capillary loop. But there was IgG also, which was showing minimal granular staining. Weighted IgG subclass, it shows dominantly IgG4 subclass, and there was some IgG1 also. So kappa lambda showed equal staining, PLA2 was negative, and there were presence of these kind of electron dense deposits which are there on the subepithelial side. That means we are dealing with membranous. But along with that, towards the subendothelial side also, there was some subendothelial expansion with multilayering. So this suggests that there is combination of MGN as well as chronic antibody-mediated rejection. So in transplant biopsies, 1 year post-transplant, if patient has proteinuria, then you should all, and you find IgG and C4D also, which is positive, then before thinking that this could be recurrent MGN or PLA2R associated MGN, you should also think that chronic antibody-mediated rejection can be followed by membranous. So this is called as a de novo MPGN. So what happens is chronic antibody-mediated rejection causes disruption of the glomerular basement membrane antigens, and some of the cryptic antigens, they are exposed, and the antibodies are formed against those cryptic antigens, leading to formation of immune complexes. Okay, so this is following the chronic antibody-mediated process. Those cryptic antigens are exposed. So this is the pathology behind MGN de novo, which occurs following antibody-mediated process. Class 2 DSA was positive, and the moment the plasmapheresis was given in this patient, multiple sessions, the proteinuria regressed. Okay, that means that this MGN was driven by antibody-mediated process. So this is just a data to highlight that we analyzed 160 renal biopsies, 136 native and 24 transplant over a period of 6 months in order to assess the contribution of EM to the final diagnosis in the knowledge of the light microscopy and nephrosis finding. And we divided these into 3 categories. Category 1, EM is absolutely necessary for final diagnosis. EM has supporting influence to final diagnosis. EM appears redundant. So only 14% biopsies EM was done. So so that means very few cases are subjected to electron microscopic examination. So out of 812 native biopsies, 136 EM were done, and out of 324 transplant biopsies, only 24 EMs were done. And this was a distribution of 136 cases of native kidney biopsy where EM was done. And what I want to highlight is the EM category 3. That means EM is redundant or not required. This include 9 cases of membranous, 6 cases of TMA, post-immune glomerular nephritis. So these are the categories where EM is not required, which I've shown you in membranous also. EM is hardly required now with so many, with IgG subclasses, PLA2R thrombospondin. So EM is hardly required. EM will be very useful when you find a FSGS lesion, or when you want to say that there is a diffuse podocytic foot process or effacement of focal podocytic foot process effacement. So in 19% cases, EM was absolutely necessary. So in cases of MCT, FSGS, IgA. So this was IgA which had massive proteinuria. So it was IgA with MCT. Diabetic patient with massive proteinuria, and diabetic morphology can't explain that kind of massive proteinuria. EM is required because if there is a sudden onset proteinuria in a diabetic patient, you should always suspect a coexistent minimal change disease. Lupus nephritis, mainly to diagnose lupus podocytopathy or a class 5 lupus. C3 glomerulopathy, it is required in all cases because it will differentiate whether it is a DDD or dense deposit disease or C3 glomerulonephritis. MPGN, immune complex mediated MPGN, not required, but MPGN with dysproteinemia, you should do EM in these cases. Proliferative GN, not significant. Cast nephropathy, not required. Yes, cast nephropathy, it is required just to rule out coexistent disease like early amyloid associated with cast nephropathy. So I'll just also, so what I want to conclude is that EM is a technique that continues being very useful in daily nephropathology practice. And ideally, all the native kidney biopsies and some kidney allograft biopsies must undergo EM. Uh, and EM will be useful for demonstrating GBM abnormalities, distinction between primary and secondary podocytopathy, MPGN pattern. You should always do C3 glomerulopathy, including PAGN, proliferative GN with monoclonal deposits, early amyloid, C40 negative chronic AMR, early chronic AMR, and if we are dealing with chronic AMR with coexistent GN. So as Dr. Mark has says that electron microscopy provide essential or helpful information to a substantial fraction of cases, and whether a biopsy will fall into the later fraction is not apparent from the clinical history. So ideally, we should always keep tissue adequately handled for EM and to carry out the study according to the results of the LM and IF. Thank you. So I'll go through this chats. So working for establishment. So if immediately after biopsy glutaldehyde is not available, which medium to be used to keep the core? So this was a question asked by Dr. Mehak Singla. Okay, so if you don't have glutaldehyde in the OTs, you find Sidex. Sidex is not exactly like glutaldehyde, but it is a more concentrated form of glutaldehyde. So you can place it in Sidex also if you don't find glutaldehyde. And as I've told you, if for example, you are able to take out only one or two cores, then we can always do electron microscopy on the formalin fixed tissue. You have to remember one important thing. If we do electron microscopy on the formalin fixed tissue, picking up the GPM abnormality is difficult, because if somebody asks me that can we measure the GPM thickness on paraffin embedded tissue, it is difficult. Can we assess the foot process effacement because of the degenerative changes when you do EM from the paraffin block? EM from the paraffin block. So there will be some foot process deterioration and all that stuff. So interpretation becomes a problem. But yes, I must tell you, there are good number of, like I would say around 60% of cases where we do EM on the paraffin embedded tissue, and 80 to 85% times we are successful in giving you the final diagnosis. Ideally, how many days required for EM processing or reporting? So ideally, if you ask me, if you look at the Western literature and all that, because EM is readily available in significant number of institutes, so what happens is EM takes around 4-5 days for because many times they report EM along with light microscopy and immunofluorescence. But in India, the problem is EM is not readily available. So, and there are few labs which are doing that. So for example, there are academic institutes which are doing. So out of those academic institutes, if I look at the private labs who are doing EM or private hospitals, there is Jaslok Hospital, there is one Dhirubhai Ambani Hospital in Mumbai, which is doing EM, then Lal Path Lab. So what we do is we get our technical part done from the Lal Path Lab, and I do the reporting on my own. So ideally, a person who is reporting LM and IF, he should report EM also. So we get the technical part done. How much time it takes? Initially, it used to take 14 days. But now with the current kind of scenario, there are cases which are getting delayed for 21 days also. But we are trying to cut this short. So if it would be ideal, would be in our setup, if we get EM in 10 days, that is good enough. But we are not getting it. It is taking more time because there is only one lab which is doing in India. So majority of the EM are going there. So and there is only one EM which is there. So if they get another EM, then obviously the TAT will get reduced. So until how long can we use formalin fixed tissue? So ideally, it should not be older than 6 months. I have never attempted doing EM on tissue mold older than 6 months, but yeah, I've seen it works well. I have seen cases where by 4 or 5 months we did EM and it works very well. Okay. So if there are any further doubts, okay, fine. So Puneet?
Yes, sir.
So if there are no further doubts, and we can stop.
Right, sir. Thank you so much, sir.
Thank you. Thanks.
Thank you, sir. It's always our pleasure, sir.
Okay, sir. Bye.
Thank you.
Good night.